So I think one of the most exciting things at this meeting and sort of at the recent ASH meeting, and probably coming up at the next ASH meeting too, will be all the BCMA-targeted agents. So we have a couple of different agents that are already approved for patients with relapsed and refractory myeloma. So there's the antibody-drug conjugate, Belantamab, mafodotin, and then of course the two CAR T-cell products, ide-cel and cilta-cel, that have been approved. And they're approved in later line settings, which is where we've used them most. So in patients who have had 3 or 4 prior lines of therapy. But I think they are so active in that setting, response rates that are well over 70%, deep and durable responses. So I think there's a lot of interest in moving those agents up front. So, I think we don't have a ton of data yet. There are ongoing studies that have looked at the CAR T cells, at least in sort of the second line setting. So these are in patients who have either refractory disease or refractory to induction therapy, or patients who relapse quickly after initial induction therapy. It's been tested in that setting, and so we're gaining data there, and I think it may become an option for those patients. And I think then there's the question of, can we really bring it into the first line setting and replace either our standard induction therapy or potentially replace transplant, for instance, with CAR T cells. And I think that's an area where people are sort of still designing clinical trials. I think in some ways we are a little bit damned by our success. The standard induction with a triplet like RVD or a quadruplet like Dara-RVD plus transplant leads to such long remissions and such good overall survival that in order to beat that, you really have to do very long studies. And I think it's going to be, it'll be challenging to sort of prove that a CAR T in the upfront setting is better than what we're currently doing. So like the idea of using 2 different BCMA agents, one during the sort of the initial induction phase and then CAR T, I think that's another open question. We've certainly started to look. We're seeing more patients now in the relapse setting who were exposed to Belantamab and then CAR T or vice versa. And some of those patients do respond, but I think there is going to be some cross-resistance, between different BCMA-targeted agents, and so the response rates will probably be lower than the first time you're exposed. So I think we'll have to be a little bit careful about how we sequence those agents, and it may be that we use immune-targeted therapies, but they don't all target BCMA. So there are other antigens that are being developed, are being targeted by specific antibodies and CAR T cells. For instance, GPRC5D is another antigen that's being targeted, and there's both a bispecific antibody and a CAR T cell that targets it. And there are other bispecifics targeting additional antigens on multiple myeloma cells. So you could imagine having a BCMA-targeted immune therapy followed by an immune therapy that targets a different antigen, or even giving them both together and sort of hitting the myeloma cell in multiple ways.